Hey everybody, I'm Jess Lupini, and this is The Words Don't Fit the Picture, the show where we untangle the strange and fascinating relationship between gender, voice, and identity. Whenever you get a group of trans people together talking about voice, something that invariably comes up is the topic of voice surgery. That is to say, surgically altering the pitch or quality of your voice in some way. Everyone has their own opinion about it. Some are glowingly positive and some cautiously negative. I wanted to go right to the source, skip the misinformation, and have a really frank discussion about what is and is not possible in the operating room. So, I am very excited to be here today with Dr. James Thomas, who's also known as the Voice Doctor. He's a laryngologist based out of Portland, Oregon, and he's become one of the leading experts in pitch-altering surgery, sometimes known as voice masculinization or feminization surgeries. So, welcome, Dr. Thomas.
Great to be here.
We're recording remote. I'm here in Vancouver, and you're at your home in Portland. So to start off, could you tell us a little bit about you and how you got into this field?
Sure. To make it brief, it was a couple of things coalesced. I became an otolaryngologist doing general ENT, and my personality is I like doing something really well as opposed to doing a lot of things average. And there's a role for both kinds of doctors in this world. And I couldn't keep up with everything and had looked at doing ear surgery because I like sound, and I ended up going to a meeting, finding this new machine called a stroboscope, and deciding to do voice, which also is sound, which wasn't very popular at the time. There were 2 or 3 well-known individuals in the profession, and I decided to focus just on voice. So that was the beginning of that.
Very cool.
And when I started doing just voice, what happened was there was sort of a little epicenter here of transgender work. Toby Meltzer was here doing work, and he was dabbling a bit in voice, but not as a laryngologist, but as a facial plastic surgeon, and he asked if I would help out. And I said, sure, I'll help out. It seems up my alley. I'm doing voice. And I started helping out in surgeries that they had already been doing. And they had published a paper together, another colleague and him, and thought that they were getting fair but not great results. And I did about 15 with him, and I felt the same way. And so that was my initiation into laryngology, and then within 2 or 3 years into the subspecialty, or let's call it a subspecialty of voice pitch modifications.
Right. First of all, I do have to ask, what is the stroboscope? What does it do that you were so excited about?
So, yeah, so the laryngology is filled with really nice toys. I have nice computers, nice video recording, and really what developed the field a lot was the cameras, the endoscopes, the things that go in your nose or mouth and take pictures. And part of that is that the vocal cords, when I'm talking to you here, my vocal cords are vibrating 100 times a second. It's all a blur, and the strobe light is a piece of equipment designed to detect your voice, detect the pitch, offset the vibration, and give you an effective slow motion view of the vocal cords vibrating.
Oh, very cool. So that's what's used, like in all of the videos that I've seen from scopes where we're looking at the vocal cords vibrating. So it's that
Yes.
strobing that allows us to be able to see the movement.
Yeah, it all looks like everybody's vocal cords are moving 2 times a second in the whole world.
Right.
Because that's what the stroboscope is offsetting it at.
Oh, that's really cool. I've actually always wondered that, because whenever I see these videos, I'm always like, they seem to be moving way slower than you need to vibrate something to make sound. Okay, that's really cool. So how big is the subspecialty, I guess? How many people are out there doing some version of what you're doing on a daily basis?
Well, I could start with the very narrow end, those of us that are doing gender pitch-changing surgery. A number of us got together 2-3 years ago in Berlin to form a new organization of gender voice surgeons. And there were about 10 of us that got together at that. And of course, there's more people in the world who do it than that. And that's growing, but that's a pretty small number of people around the world to be doing something like this particular field. So
wow.
So it's growing. It's growing, and it's growing rapidly. And the thing that really started it growing, I would say, is I've been doing the surgery since the 90s, various kinds, the crinkly thyroid approximation, and later the feminization of laryngoplasty, some webbing. And I think that the two things that changed are the WPATH organization got this out of the psychiatric handbook into the medical one. That meant insurance was going to consider paying for some of the surgeries. And as soon as insurance started paying, all of a sudden, every university wanted to have a piece of the action. So every university suddenly had a laryngologist who was going to do something. And the second thing that came together was vocal cord webbing became popular about 5 years ago because it's a detailed surgery, but it's an easy surgery. There's not much downside to it. And so many surgeons adopted that. So new procedure and insurance paying for it, and it's led to a big popularization of let's do something to alter pitch.
You've mentioned a couple of the different procedures that are involved. What are the pieces that we need to understand in order to understand the procedures that you're going to be speaking about?
Well, I think, first of all, voice is physics, and even doctors aren't trained in physics very well, or they've forgotten it. Surgeons like to see something, cut it out, so have a cancer growing on your skin, you cut it out, people are better. But that doesn't really work for voice and sound. And if you really want to change the voice, I think you have to understand physics and how sound waves are modified. So in your neck, you have vocal cords, where the Adam's apple is, approximately the middle of the neck. And the vocal cords do nothing but vibrate and make a tone. So if I'm saying, ee, that's essentially almost all vocal cords. And then everything above that, my throat, my mouth, my nose, sinuses, those cavities are like the body of the guitar or the brass and the trumpet. And that modifies the sound or resonates the sound and gives you a characteristic. So when we think of a gender, a person, we hear a voice and we hear gender, we're hearing the voice, the pitch, and we're also hearing the modification of that, the resonant cavity. And depending on the size of your vocal cords, the pitch is different. And depending on the size of your resonating cavity, that quality or the overtones that we hear is different as well. So 2 parts to identifying gender, the pitch and then the resonating cavities.
Gotcha. Okay, so when people hear or perceive a difference between a male sounding voice or a female sounding voice, what differences are they actually hearing?
Well, I think they're hearing both of those. It would be like you could listen to a tune on the radio and you can hear a song and you recognize the pitch there, even if you aren't a musical expert. A musical expert might be able to tell you it's pitch C4 or something exact. But most of us would recognize the whole overall song, and that's kind of complex. So your question is in a way complex because it's not just the pitch. We hear lots of things, and it makes us think male, makes us think female, makes us think we don't know. In between, because we get a mismatch between resonance and pitch.
Right.
So I think it's the interaction of both pitch and resonance that somehow our brains process it, match it up to everything we've seen in life, and we say, I think that's male, I think it's female, or I don't know.
Okay, so let's say, for example, in the case of trans feminine people, when you're trying to go from a voice that sounds more male to a voice that is perceived as being more feminine sounding, what are the goals in terms of the pitch and resonance? What are you trying to change?
Well, let's break it down into, there's a number of surgeries that you mentioned, and before we detail them, there's also voice therapy.
Right.
And voice therapy is trying to use your own muscles to change the pitch and the resonating cavities. So some people can do that because they have great vocal rapport. They can do it themselves. Some people can do it with coaching. And you're altering typically both the pitch and the resonance. So that's what you need to accomplish. And if you're going to do surgery, then you have to decide, are you going to alter pitch only, pitch and resonance, or you're going to do some type of surgery and add therapy back into it.
My understanding, correct me if I'm wrong, is that a lot of your work when it comes to vocal feminization is essentially attempting to undo some of the effects of testosterone. Is that Do you say that's true?
I would say that's almost 100% of the whole problem. In fact, shoot, if you could get to somebody before puberty, you wouldn't need a surgeon. So,
Right.
yeah.
So what does testosterone change about the voice?
I think it changes two things, and they are, one, in the vocal cords themselves, the sound production. The vocal cords aren't quite strings, but we think of them as chords or strings because they vibrate, and it's a good analogy. Those strings get longer and heavier, and pitch is determined by mass, length, and tension. And so when you get exposed to puberty and your Adam's apple starts to protrude forward, inside, that's the vocal cords becoming longer. And then puberty also affects resonance, and it starts to drop the larynx or the voice box down lower in your neck, which means on the inside, your throat is getting bigger and wider, and it's starting to resonate and amplify the low tones. So you're going from a trumpet to a tuba, let's say, inside the back of your throat. So testosterone modifies both the voice and speech, and those are the anatomic structures, the vocal cords and the pharynx, that change with testosterone.
Got it. Okay, so before we get into what's possible today and some of the newer procedures, we've mentioned the cricothyroid approximation a few times. So
Right.
What is the cricothyroid muscle, and what is the cricothyroid approximation surgery?
Yeah, so I think in the 1970s, there were a few case reports or 3 or 4 reports of surgeons trying various things to try to modify a male voice and make it feminine. And the one that seemed to stick around in the 80s and 90s, at least a few places doing it, was the cricothyroid approximation. It was an easy surgery, and the cricoid and the thyroid cartilage are the two main parts of the Adam's apple, and there's a muscle between them, and when we tighten it, then our voice goes up in pitch because it pulls the vocal cords really long. So the muscle that takes us up into falsetto, the cricothyroid muscle, it gives us about half of our overall range. In fact, if I were talking here or singing and I went from my low note, E, that's mostly the vocal cord muscle itself, the thyroarytenoid to be technical.
Okay.
And then to go from E, that's mostly the cricothyroid muscle, and those two muscles work together. So the cricothyroid approximation is a stitch through the cricoid and thyroid cartilage, tensing the cricothyroid muscle permanently. And it's no longer useful to you because it's effectively been stitched tight and it can't move anymore.
Right.
And in some cases, then voices will stay at a high pitch.
Interesting. So that cricothyroid muscle is mostly engaged in falsetto and like hitting those like very high pitches, right?
I think that's close to being as accurate as we can.
Right.
Is that muscle basically gives us our falsetto range.
Okay, that's fascinating. So obviously the male sounding falsetto does have a very different quality from what people think of as like a cis female sounding voice.
Right. There's 2 reasons for that. One is when you tighten the cricothyroid muscle, you pull the vocal cords thin, so they kind of have a different quality in their vibration. And 2, you still have the resonating cavity hasn't changed. So when you hear a countertenor singing, when you hear a gay male talking, when you hear me try to tighten my cricothyroid muscle, those are all using sort of the same change in the physical structure, and so they sound a certain way.
So can we listen to a couple of the examples of what this sounds like?
Yeah, let's listen to one. This is a cricothyroid approximation, a person before surgery and after surgery just doing a standard reading.
Okay.
Long ago, men found that it was easier to travel on water than on land. Long ago, men found that it was easier to travel on water than on land.
Okay, fascinating. So I think I can hear what you're describing there, where it does sound like there's more tension in the voice. It has a very different quality to it, but it is higher.
It is definitely higher. So if you write a paper, cricothyroid approximation looks great on paper. It does raise the pitch in a lot of patients.
Okay, I love that you say it looks great on paper. Can you Can you tell me more about like what you're getting at with that?
Well, so in medicine, or science in general in medicine, the idea of being peer-reviewed is considered the highest standard. So you do something, you do some science, you write it up, and you get a colleague to say this is a good job, and then it gets printed in a paper. And if you go from a low pitch to a high pitch, that's generally felt to be good, because if we took, say, the average cis male, they speak at a certain frequency, and an average cis female speaks at a higher frequency. And so if I'm talking like this, my frequency went way up, but it may not sound feminine. It may sound like falsetto. So it looks great on paper because you get big number changes, but there's several problems with the trichlothyroid approximation. One is the quality, which we can hear in the clip. And a second is that even though you tighten this joint, the muscle often stretches out. And in my hands, about a third of patients 2 months later went down back to their original pitch, even though this muscle was permanently tightened. So it fails in a couple of ways. It can fail in quality, and it can fail in pitch.
So the pitch would drop down in a fair number of patients, but the muscle stays permanently tightened. Does that mean that they're losing additional control of their voice, even though they've lost that pitch that was gained?
Yeah, I think they've lost the ability. They lose about half their vocal range. So now they're limited to half the range. If it stayed high, they might be happy with it. And if it drops down low, now they can't get up to the high notes anymore. So it has a pretty significant downside.
So this procedure in general is like around 50 years old at this point today. And it seems like most of the work is being done on a muscle that does affect pitch, but isn't necessarily one of the core like structures that affects the way that a cis man and a cis woman tend to sound different from each other. Is that right?
I think so. I think the other thing is that it's a very valuable muscle. You hate to get rid of it.
Right.
It's something that we can use to raise pitch. So if you get rid of it, you've lost something, yeah.
Okay, so can you tell me about at what point you stopped engaging with this particular type of surgery? Or maybe it's better to say, like, how did your views on it change as you moved through your career?
Well, I was noticing some people weren't staying at a high pitch, and so I tried thinking about what else I could do. At the same time, then I had a patient who was locked into a single pitch after the surgery.
Oh my
She really couldn't go up or down. So I think if you pull that joint tight enough and you fix someone into a single pitch, especially someone who does not identify with that pitch, you've really impaired them. It was the combination of not great results and having a patient that was severely impaired that I felt like I needed to look around for something else to do.
Tell me, what does that mean? Like, I know if I get bored and I'm like, I'm going to look around for something else to do, I can't imagine how I translate that to medicine and especially surgery. Like, how do you go about being like, what's another option here?
Well, I think there was two ways I went about it. One is a typical way, which is to delve into the medical literature, go read a lot of papers, see if someone else has written something. And I did that. And one of the things I came across was a surgeon, Dr. Kunacek from Bangkok in Thailand, who had done a series of 4 cases and said sort of kind of had good results. He had mentioned taking apart the front of the voice box and pulling the vocal cords tighter. So there were other ways of trying to tighten the vocal cords that I read about, and that one fascinated me. And at the same time, in the mid-90s, there was this thing called the internet, and I'd started a website, voicedoctor.net, because I thought, well, this is pretty cool. And on my website, this is now early 2000s, I posted this idea that, well, maybe I should do some sort of evolution and try to get away from the CTA, leave that muscle alone, and maybe take apart the voice box like Dr. Kunacek had pulled the vocal cords forward. And I thought if I put it all together and I could take a male voice box and make it look female, then the physics would be there to make the voice sound more female. So I put on the website this idea and said, I'm interested in doing it, and just left it there. And I got a call from an engineer in Texas, and she said, you know, I'm really interested in this idea. I've heard all these voices of surgeries, and they don't sound that great to me either. And I like your idea, and I'd kind of be interested in being a guinea pig, and we can work together on it. So she and I got together, and we talked about it for a while, and then eventually she came up, and we did the surgery. This idea of, based on Dr. Kunacek, of taking off the front of the voice box, which is what he did, and then opening it up and trying to shorten the vocal cords, trying to tighten them, and then going a step beyond that and trying to change resonance, which was for me to try to lift the larynx up in the neck and shorten the throat. And I thought the more things I do to mimic female anatomy, the more the voice is going to sound feminine. And this lady and I, we did it. We did the first case awake, which was interesting. And it's not a very painful surgery, even though I'm splitting the neck open. But the problem is, a lot of my patients are very chatty, and she was chatty. And she was trying to talk to me while I was trying to sew her vocal cords up. And I thought, I'm gonna rip something that I don't want to rip. And I got her back together, and she had a better voice. And I thought, well, I better not do this awake, even if it doesn't hurt. I really need everything to be perfectly still while I'm sewing on it. So anyways, that was a start. And her voice is pretty good. I went in and modified her about 3 months later and tried to tighten it more. She liked the voice but wanted something better. And then we watched her for a while, and about 6 months later, I did a second patient, and then she worked out, and that's kind of the beginning of the flow of switching from cricothyroid approximation to this surgery, which I call feminization laryngoplasty, because that sounds pronounceable, where if I said to someone, I'm doing an anterior partial vertical laryngectomy with resection of the anterior vocal cords and elevation of the larynx in the neck and shortening of the pharynx, it's kind of complex to name all the parts of the procedure. So that's how I started with that.
And so I've seen that referred to a lot as femlar. Is that just a joining of feminization laryngoplasty?
Well, that was the first patient said, we started talking about it. She said, I'll just call it femlar, because she thought even feminization laryngoplasty was a bit long. And so just kept using femlar because it's short, quick, it's kind of like an abbreviation and easy to say.
Yeah, it's catchy. So let's listen to some of the femlar before and after samples.
Long ago, men found that it was easier to travel on water than on land. They needed a cleared path or road when traveling on land, but on water, a log of wood or any large object that would float became a man's boat.
Long ago, men found that it was easier to travel on water than on land. They needed a cleared path or road when traveling on land, but on water, a log or wood or any large object that would float became a man's boat.
Long ago, men found it was easier to travel.
Long ago, men found that it was easier to travel.
Long ago, men found that it was easier to travel.
Long ago, men found that it was easier to travel.
Long ago, men found that it was easier to travel.
Long ago, men found that it was easier to travel.
Wow.
Long ago, men found.
Long ago, men found.
It's such a striking difference compared to the cricothyroid approximation.
Yeah, I think that's consistent. I mean, now I'm up over 350 patients, and I have follow-up recordings on about 280 people. And I would say, I mean, there's a wide variety of results, sort of a bell curve of pitch. But in general, I think the modification is getting people much closer to a feminine voice. And some people, it's complete. I think my second patient was one of my best results. And as she said, you know, I stopped being a trans woman when I got the surgery. I became female, went out in society. I stopped going to meetings. I just live my life now as I'm meant to live it. So that's a pretty high bar, but I thought it was a bar that she felt really seriously happy about. So, and that doesn't happen to all of them. So that's the good ones. But anyways, when it works really well, it works really, really well.
Let's talk a little bit about what the quote-unquote success rate of feminization laryngoplasty is, especially compared to the cricothyroid approximation. I think you mentioned 30% was what we were looking at with the CTA. Is that right?
That's my take on it. If you read articles online, you probably would get 25%. I think For me, it was close to a third, 33%.
Gotcha.
There's not a lot of if you added up all the articles, there might only be 30 or 40 people reported on. But yeah, that's a 30% failure rate. And then if you count the quality, I would say the failure rate's up above 50%. So
right.
I strongly discourage anybody from getting a CTA. Get any surgery you want, but don't get a cricothyroid approximation.
Okay, and so what's the satisfaction rate like for FEMLAR?
Well, it's interesting because satisfaction and outcomes are kind of two different things.
Okay.
There's a whole bunch of ways to measure success. So let's take the standard way that's going to be in the medical literature is pitch. And with this particular procedure in my hands, FEMLAR, the median outcome is 6 notes on the piano.
Okay.
Elevation of pitch. And I like the piano better than Hertz because I can't think in a logarithmic scale. So pitch, I like the tones on the piano. Most people can count 6 notes, you know, do, re, mi, fa. So technically, it takes you on average from an average male voice to an average female voice. But of course, the starting point could be a low bass, and they're not going to get 6 notes is not going to get them up into a female range. And of course, that's the median. So there's some people that get 8 or 9 notes. And there's some people that get 2 or 3, and they aren't that different afterwards. So and if I look at it and plot it, it's a bell curve. And so the middle 50% of people get average results, and average is often good enough for some people.
We've obviously listened to what some of the positive outcomes can be, which is this incredibly gender-affirming procedure where you get to then move through the world afterwards without having to think about voice, which is something that I know a lot of trans people are very self-conscious of, myself included much of the time. But what are some of the downsides and the common risks that you see?
When I talk to someone about feminization laryngoplasty, it's a big surgery. I'm taking the entire larynx, opening it up, deconstructing it, and reconstructing it, putting it back together. And the initial risk is having an infection, and because I'm going from what's called a clean area inside your neck, has no bacteria, and I open up inside your airway, which has lots of bacteria. So there's a risk of infection, and if you get an infection in your voice box, that can impair your breathing. So it's kind of a high-risk surgery, and something that I try to mitigate the risk but not eliminate it with antibiotics, watching closely for any signs of swelling. So early on, higher risk than any other voice surgery about infection. And then long-term, the risk is, do you get a female voice? Can you further modify it? Have you burnt bridges, or can you still do more? If things don't heal well, you can get a rough voice. You have 2 vocal cords. If they aren't even, you can have a double pitch, have a raspy voice. Any surgery that shortens the vocal cords reduces the volume, so most of my patients have lower volume, so we have to have a conversation about noisy backgrounds, lifestyle. Do you work in a bar or do you work on a construction site? So volume. So it's about quality, pitch, and volume after the surgery, and complications can bother all 3 of those things. So one of the things to talk to people about is if we don't get what we want the first time and we haven't burned a bridge, there may be more we can do. So if I get someone better, they've lost some of their bass notes, but they're still kind of speaking in a tenor male voice, well, there may be a different procedure to do on the inside to reduce the bulk of the vocal cords as a secondary surgery.
And what would that procedure be?
Typically, I use a laser, and I have a laser in the office where I can tighten the epithelium, the mucosa covering the vocal cords, or we can go back to surgery, and a CO2 laser is a stronger laser, and I can cut into the vocal cord, remove muscle, thin it out, and try to make it a male thickness go to more of a female thickness vocal cord.
So there's really a lot of different procedures that are all kind of coming together in different ways to achieve these effects. Is that right?
Yeah, I think of it as a toolbox, and the toolbox that the patient has is speech therapy plus some type of surgery. And if that surgery is the feminization laryngoplasty or even webbing, and you get partway to where you want to go, there may still be something else to do. And so the initial surgery plus lasers can sometimes work together. Actually, I need to interrupt because I'm getting a call from the hospital.
No worries.
So let's stop for a second.
Hey everybody, this is the perfect time to take a break. So, in the next episode of The Words Don't Fit the Picture, we'll conclude my conversation with Dr. Thomas. Part 2 is full of great stuff. We're going to talk about vocal cord webbing, trach shaves, recovery times, how much patients can expect their ranges to change, medical ethics, and so much more. So, tune in next time on The Words Don't Fit the Picture for part 2 of this fantastic conversation with Dr. Thomas. Thanks so much for watching, and I'll see you next time.